Good evening, everyone. So on tonight's agenda, we're going to review the miniBunion 3D system with Viking instrumentation and show you kind of the tips, tricks, and pearls. I'm joined by Dr. Young, Dr. Moore, and Dr. Curie to also help with case reviews. So I'm going to review kind of the system, the idea behind it and how it came to be, as well as the surgical technique with all the new instrumentation. And then Dr. Young, Dr. Moore, and our Curie are going to share with us some cases, and we'll do some question and answers at the end. So without further ado, I will go ahead and start the program. And for those of you who have kind of followed my career, I did a fellowship with Dr. Herzenberg and Dr. Paley, and learned all the deformity principles and Cora and so forth. And I was one of the ones that kind of utilized those deformity principles in Cora and applied them to the foot and ankle. And it also, with any deformity correction, bunion is one of them, you need to know what normal is to then take your abnormal deformity and create a new normal. So the osteotomy rules are important principles along with the Cora, and I'm going to show you how the Cora relates to the osteotomy rules and our correction of our bunions. So if you have a bunion as shown here, this would be Osteotomy Rule 1, which would be where you make the osteotomy, or in this case, the fusion, the lapidus fusion at the level of the Cora. And where the yellow and red lines intersect, that's your Cora, which is at the Lisfranc joint. You do your osteotomy and you line up the red line over top of the yellow line to correct your deformity. And that's Osteotomy Rule 1, where you osteotomize or correct the deformity at the level of the Cora. Here's Osteotomy Rule 2, which is if you have a Cora, in this case, in the proximal to the Lisfranc joint as shown here, in this case, more of a mild bunion or moderate bunion, you do an osteotomy, say a distal osteotomy, in this case, kind of a chevrons translation osteotomy. You can correct the IM angle, which corrects the Cora, but you're doing Osteotomy Rule 2, which is, where the Cora is, you're just making an osteotomy distal to that, and then the distance, if you see between the red line and the yellow line, at that level where you make your osteotomy, that distance, you have to translate the osteotomy to realign your access lines, which gives you the correction. So that's Osteotomy Rule 2. So that's a wanted rule and an understood rule, but you are having to do translation to correct the deformity based on the Cora principles. How about Osteotomy Rule 3? This one I learned the hard way, where here's your Cora proximal at the Lisfranc joint. You make a opening wedge osteotomy, but what you do is you create unwanted secondary translation. So on the right-hand screen, your red line should overlap your yellow line, and they don't. Although you don't have an IM angle deformity, now you created a medial translation of your first metatarsal, which leaves your sesamoids uncovered, leaves your bunion deformity still present. So this is the unwanted rule, Osteotomy Rule 3, where you make the osteotomy away from the Cora, but you do not translate. So this osteotomy should have been translated medial to correct based on Cora principles. So I think a good basis, a lot of talk with bunion deformity lately, but this is kind of the basics, and this is something I taught for years at the limb deformity course, and like I said, had looked into closely to really understand this. So MIS surgery is kind of new in general to a lot of surgeons. We learned with open traditional procedures. So this is a new technique, and we'll run through it with you. So more of a mild and moderate bunions we're treating with this more minimally invasive mini-bunion procedure. So where did this kind of minimally invasive bunion surgery come from? Well, there's a lot of history, but the most notable kind of history is Bosch's technique, which kind of really gained favor in the 2000s. And basically, it's an osteotomy of the metatarsal through a small incision. You can use a burr, you can use an osteotome, you can use a saw at the neck, and then you're translating it just through a mini incision. And then you're fixing it kind of with this stymon pin that goes down the medial column. So you're kind of shish kebabbing or skewering the medial capsule, and then you of the great toe joint, and then you're pushing it into the shaft of the first metatarsal. So this is kind of relative stability, not really ultimate stability, but you do get bone growth, and you have a small incision. And this worked very well, as you can see here, just a case example of this technique. And you see the remodeled bone, even though you see, 80%, 90% translation of the osteotomy, the periosteal envelope was still intact due to the minimally invasive nature, and you see remodeling on that lateral side post-operatively. So Bosch published multiple papers and followed with 10 years, 81% satisfaction rate. They used the K-wire or the stymon pin type wire. It was a 2.0 wire, 2.0 millimeter wire for 1 month, and then they removed it in the office. And Mann and colleagues in 2003 showed 91% satisfaction rate. And later, other studies showed very similar 92% satisfaction rate. And there has been a lot of published studies, not large numbers, but published studies showing that, the minimally invasive Bosch type technique is satisfactory to patients. The idea of this mini bunion really came from, reading these manuscripts, looking at this closer, and me having learned the traditional bunion surgery where you make the large open incision, chevron, or whatever type of osteotomy. But, I was always concerned about complications, but I never really saw much of the first two or three problems. They kind of more common with the open traditional procedure as you go from 1 to 5. So, avascular necrosis, delayed union, some maybe recurrent deformities, incisional neuritis was a pretty big one, and then definitely limited motion. And I felt like, oh gosh, I can do better with bunion correction. I was, dissatisfied with it. Patients were painful. They couldn't move their great toe. You had to send them to therapy a lot. And the concern was, well, I could get, 8 out of 10 people well, but maybe 2 people had some stiffness or scarring or difficulty with function. And if you read the data, it shows that most people who have bunions, what they want is a functionally good result first, and then second, reduction of pain and so forth. So, so looking at that, coming up with how I can do this better, the bunion surgery, I came up with the kind of minimally invasive ideas, but expounded on kind of the Bosch technique. And basically, the real advantage is a small incision. So patients like that, and it's less scarring. You have immediate weight bearing. You can correct frontal plane alignment. You get significantly less pain. And I've seen that in my clinical practice. Patients come in week 1 and they're like, I have to hold them back because they're feeling really good, and much less pain than traditional surgery. And then most of all, function. Patients are very functional and they can have an active recovery, plus they are very functional afterwards because the motion of the joint is maintained. This is kind of extra capsular procedure. You're not scarring the capsule, you're not invading the joint, and that allows patients to be very functional. And again, that's the number one rationale why patients are happy with their bunions. So my old technique was basically doing the Bosch technique. I published this in 16, where you just do the osteotomy, translate, and then I did a percutaneous screw fixation. And this was worked well, but unfortunately the stability was better than the Bosch technique because I had a lot of patients with that wire get infected. They have a lot of irritation, they're weight bearing, the joint's trying to move, but the wire is kind of limiting the motion. So the wire was creating a lot of problems. So I did more of an internal fixation technique. That worked pretty well, but it wasn't so stable. And I had some really difficulty times with swelling with the wire and the screw because of its ability not to be too stable. And then basically from that came up with this. I love the technique of not invading the joint and doing it minimally invasive. Patients like that, as well as coming up with a more stable construct that not only would stabilize the osteotomy and allow for earlier weight bearing and quicker healing because of that with the bone healing, but also having a device that can control some soft tissue correction medially if you wanted to suture the medial capsule, which has the implant itself has a hole that you can pass suture through to reef the medial capsule if you so desire. So now with being out for 2 years, we've made some adjustments in the equipment and a bit of the technique, basically to make it more simple for the user. And we're going to share with you those simplifications. But basically, we want to do the osteotomy, then we want to control the osteotomy, the capital fragment to rotate it, angulate it, translate it where you want. And we have a special guide for that. That's the Viking guide. And then you want to be able to fixate the proximal distal fragments so that you have very good stability. And then you have the option of the soft tissue correction. So these are the two newer advances in the technique. This Viking guide, as you see on the left, it's a guide that is placed dorsal and allows you to kind of control the metatarsal head, and we'll show you this later. But basically, it allows you to control the capital fragment so you can obtain the position that you want, and then it can be maintained while you insert your fixation. On the right, you see the guide was adjusted. What we found in our earlier patients is that if you'd use an oscillating saw to cut the bone, or if you use an multiple drill hole and an osteotome, it heals the same. And most physicians tend to use oscillating saws. So what we did is we made a guide that's very precise for that saw blade, and basically allows you to insert the guide and then use that guide as your cut guide and do your oscillating saw osteotomy. So having a precise osteotomy guide and a well-controlled Viking external device that allows you to maintain the position that you desire has really advanced the ease and simplicity of the system. So this is just a technique overview. I'm going to run through on this video here the technique for you via an animated guide. You know, the big thing is you have to use fluoroscopy a lot more with these minimally invasive surgeries, so you can make sure you're in the right position, because you can't see everything. So you want to use like a bump. You basically use the bump so you can get 90-degree imaging. You use a wire along the first metatarsal laterally there, and you draw your central axis line on your first metatarsal. Then you want to draw the joint line so you know where your joint is located. And then second dorsal line will be at the neck of the first metatarsal. Just a bit proximal is where we're making our osteotomy, proximal to the neck. You insert a wire at the level of your desired osteotomy. This is done under fluoroscopy guidance, 90 degrees to the first metatarsal shaft. So you want to look at the AP, and you make it 90 degrees to the shaft. Make a small 2-centimeter incision, about a 1-inch incision. Then you measure for your lengths. There's a short and a long, and that measurement allows you to figure that out. Here's the osteotomy guide. So it slides over the first wire. Then you put 2 wires in, one distal, one proximal, and then you bend those wires so the guide stays in place. You put the Viking guide on next by putting 2 pins in kind of dorsal medial on the first metatarsal head. So now you can make your osteotomy, and you can use that guide and then remove the guide. And now you have control with these 2 wires through the first metatarsal head to get your rotation, angulation, translation. You mount your implant, your intermedullary device, on the insertion device. You put your Houston passer through so you can do your capsular reefing later. You make kind of a pilot hole in the first metatarsal that kind of gives you that translation that you're looking for. and then you got to insert the implant as shown here, where you really want to make it parallel to the and you tap it in. You want to, on the lateral, you want to be up the shaft, and on AP, you want to be pretty vertical through on an AP X-ray, the implant. So you kind of make sure you got it inserted. Then we want to fix the intermedullary device to the proximal metatarsal. And what you use is this guide, and you can read right off the drill the depth of that screw, usually somewhere between a 14 and an 18. This is a non-locking screw. We put this in, and that maintains your proximal position and also maintains your translation. You don't want to over tighten that screw. Then you put your Viking device back on, and this is made easy where you can rotate to get your frontal plane alignment. I find not so much rotation needed like a Lapidus, just a few degrees. And you can use that handle to kind of compress a little bit to make sure your osteotomy is where you want it. Then when you have it, the Viking device inserted as shown, then you can lock in your distal locking screw through your intermedullary mini-bunion device, usually around a 20 length screw. I usually like bicortical in this case. Remove your block off the top, and then a little bit extra tightening on that oblique screw to get a little bit more compression. This is the kind of percutaneous capsular repair. What you want to do is just grab the medial capsule, and then what you can do is you can pull it towards the implant, and then pull this through from plantar to dorsal. Gives you a nice anchor proximally, and then you can dial in the amount of medial capsular correction you want if you desire that. It's surgeon preference, but it is available with this implant. And then a small closure of the skin. And here's kind of a pre and post-op example of what it looks like. So go on to the next slide. So I'm going to show you a few cases of mine. Here's a 47-year-old female, 10 years, bunion pain, waited for surgery because her aunt's difficulty with previous bunion surgery. So the aunt was telling her, don't get the surgery. So she waited like 10 years. Then she heard about this kind of minimally invasive procedure. And she came to me for the correction. Here you can see a pretty good IM angle, the sesamoid within the interspace there. Osteotomy, you notice I took a little bit of this medial eminence of the first metatarsal. I usually do that as well. And translation, rotation, and you can see on the right-hand side of the screen how the regenerate bone heals there medially. So, I'm sorry, laterally on the metatarsal. So this is just an example of a pretty moderate, pretty sizable, moderate IM angle. Here's the lateral, just showing you the images. Sorry, they're a bit blurry, but showing you that the position of the metatarsal head is in good alignment on the lateral. That's really critical when you are looking at the x-rays intraoperatively to align that translation dorsal plantar. And the Viking guide helps with that because it sits flush with the dorsum of the foot, so you don't get that inadvertent plantar or dorsal translation. So here's the clinical, kind of the before and after, immediate after. And then she sent me this. She went for a 1 mile run. She texted me this about 2.5 months after surgery, and then she was also snowboarding 3 months after surgery. And she's really pleased. And even though her aunt said don't do it, she's so glad she did do it. And she said it was so much easier than she thought. And given all her aunt's horror stories with her results, and this is kind of a typical story that we see with these patients. Here's kind of case 2, 57-year-old female, bunion pain for 20 years. She basically is a golfer and a tennis player. And you can see a pretty, sorry about that. Let me go back here. Pretty good IM angle, pre-op, and you see the translation. You can see this is a 4-5 implant. There's a 3-5, 4-5. This one's a little bit larger in width to push a little bit more to get more lateral translation. You can see nice remodeling of the medial or lateral aspect of the osteotomy. And here you can see really good function, not too much in the way of scar. She was really pleased, functioning well. Third case is a 47-year-old. And just to show you some intra-op pictures of putting the wire at the neck, the guide, inserting the implant, locking it proximal and distal, ensuring on the lateral you have your position. And here's just this example showing you same kind of thing, the rotation, reduction of the sesamoid position, and insertion of the implant and good healing of this patient. Here's just a before and after of her. Patients are, like I said, I'm holding them back. We'll talk about some of the post-operative course at the end of the procedure, but I do a wound check at 1 week and try to get them back to their normal shoes in about 4 to 6 weeks, depending on the patient. And then just another final example, just showing you this example. She came in recently. It's about 2 years since her surgery, and she wants the other foot done, but you can see nice regenerate bone formation. The osteotomy just a bit proximal to the metatarsal. Here's her, her right side was fixed, and now she's coming back in for her left side. So I think that says something about the procedure, and it's really been a practice booster for me because I was on the local news, and unfortunately, a lot of people want to have this new revolutionary minimally invasive bunion procedure, and I think it's been really really beneficial for my patients, and it's really been a great experience. I used to kind of dread some of those post-op 1 week visits, and now the patients are really happy, which makes me happy and makes my days much easier because they have such little pain after surgery, and they're kind of wanting to get back to activities, and I got to hold them back. So about 2 years or so of doing these procedures. The mini-bunion implant was launched in May of 2019. I've done over 225 of these cases. I have done about 3 revision cases. One was due to a patient that talked me into bilateral surgery, so she had a bit of complications because she was kind of overdoing both feet. The other one was a varus. I had a hallux varus, and that was more my doing than the implants doing. And the reason is on some of these larger bunions, I'm pushing the envelope a little bit, and they have medial eminences. So sometimes I make a larger incision for those, and I resect the medial eminence. And in her, I took too much medial eminence and got a hallux varus. And the third one was basically a revision for a infection that was a superficial infection that I basically wanted to wash out before it became a deep issue. I've taken out maybe 2% of these implants, maybe 3% at the most. And mostly I think they're kind of some of my earlier cases, but some people are bothered by the implant. I found more the medial eminence of that first metatarsal that wasn't resected tends to bother people more than the actual metal implant. But as you'd expect, some removal of implant patients and weight bearing right away in a surgical shoe is how I usually do it, and they're functioning really well, and they definitely get back to their activities and heals and all that good stuff. So I'm going to turn it over for some case reviews and insights to Evan Young.
Great, thank you, Dr. Lamm. First, I'd like to introduce our panel this evening. It will consist of Drs. Blake Moore, Evan Young, and Nicholas Arcuri. First off, Dr. Young will share his insights with us. He practices at Modern Foot and Ankle in Tampa, Florida. He received his medical training at Rosalind Franklin University of Medicine and Science in Chicago, and then served as chief resident during his 3-year surgical residency at Chicago's Mercy Hospital. Dr. Young specializes in pediatric conditions, revisional surgery, bunion and hammer toe correction, and foot and ankle reconstruction. So with that, I'll go ahead and hand it over to you now, Dr. Young.
Great. Thank you, Lisa. Appreciate it. Yeah, I've been lucky to be down here in the Tampa area since February. It's been a wonderful change from both Chicago and Arkansas, so having a lot of fun there. So basically, I'm just going to expand on everything Dr. Lamm had been discussing. First and foremost, you definitely don't want to do the wrong procedure at any point in time. So, you know, the mini bunion, as wonderful as it has been for me, and I've probably done somewhere around 60 to 70 of these at this point. I've run into a few small issues from time to time, and I think just passing along the things that I've run into is sort of the key. And so I think if we can just kind of keep the thoughts in mind ahead of time, what we're going for, that's really important. So in your pre-op planning, when I look at an X-ray, you know, this was a case that, like this picture showing, the shape of the head probably should have been an indicator for me that I was probably going to have a hard time getting the hallux sort of lateralized, just because there's that extra flare, not just medially, but also at the distal medial aspect in the joint itself. It's a pretty large flare there, and you're gonna have a hard time moving that hallux without resecting that distal bump. And of course, if you're going for an extra capsular procedure, that's going to make this a little tougher because you're going to have to get into it. The joint needs to be flexible. You need to be able to get the sesamoids reduced. If you can't palpate them reducing clinically, you're going to have a hard time reducing them in the OR as well. It's kind of what I've found. So a lot of times I'll get an axial sesamoid view preoperatively. That's pretty much my standard bunion is AP lateral and an axial sesamoid, just to kind of get a good look at where the sesamoids are, make sure that they're still on either side of the crista and that there's not significant blunting of the crista or something like that that's going to possibly create a problem. For my dissection technique, I'm super simple with this. I try not to do too much. Basically, I make a small incision after I plan my osteotomy, and the osteotomy planning really kind of comes down to where I want the implant to sit. So once I make the skin incision, I'm really just skin. It's the only thing I'm going through. Everything else is done with either a freer or a mosquito hemostat. Dorsally, all I'm trying to lift is the EHL. Not trying to create a big pocket of periosteal tissue being lifted off of the bone, obviously, because minimally invasive technique, the goal is to keep the periosteum intact. And then the latest little tip and trick that I've been passing on to people is I'll take that freer and just kind of along the plantar medial aspect of the distal aspect of the head, where I know that plate is going to end up sitting up against the medial aspect of the head. I'll just kind of free a little soft tissue pocket there to make sure that the plate will sit underneath the soft tissue as it goes in. I think next slide's on x-rays. Can't harp on that enough, how important it is to have the correct angle of the x-ray. If you're laying that foot directly flat on the plate, what you're going to end up doing is making your osteotomy way too proximal. It definitely makes the guide pin and everything look like it's much more distal than it is. So you definitely don't want to do that. You want to make sure it looks like a good AP, and that's where the little bump on the plate is helpful. Kind of depends on if you have a mini C-arm or the standard large C-arm. The large C-arm, I would definitely recommend doing it with the little cushion under the forefoot to get that 15-degree angulation. If you have a mini C-arm, it's a little easier to just kind of do it yourself. Although by the time you reposition 5, 6, 7 times, you can easily kind of change your angle. So it is something you want to look out for. So I have changed from using the standard long saw blade to using the regular 18 to 20 millimeter saw blade. The reason I did that, I've come across when I was teaching the tendency for people to want to either plunge the saw blade into the inner space between the first and second metatarsals, or the excursion on the longer blade can actually cut structures like the EHL and things of that nature. So what I will typically do is just grab the regular bunion blade and just pop the medial cortex so that I have my angulation, and I do that with the cut guide on. I remove the cut guide and then I just finish it from there. That way you have a better feel for it, and it also frees up your soft tissue a little bit more so that you can actually see what you're cutting. So, so a little more on the osteotomy planning. So you want to make this osteotomy proximal enough that if you don't need a lot of frontal plane translation, that medial eminence is not going to be in your way. You can kind of see on this picture on the left, there's a little space between the first metatarsal head and the plate that I don't want to see. If I see that when I'm doing the procedure, sometimes I'll either, before I put my oblique proximal screw in, I'll actually try to tamp in the plate a little bit more. I'll try to see if I can get a freer in there, see if I can just get a little bit more seating. I really hate the idea of that medial eminence and the plate sitting on it. I think that makes the plate more prominent, and it also creates more lateralization of the first metatarsal head that you might not actually want. So excuse my bad illustration there, but I think that was kind of what I was trying to illustrate in where to put your osteotomy, and something you can kind of look at before you do it. So on this next one, here's a good example of a metatarsal that didn't have a lot of length. I also think my x-ray was a little off, but if you're really concerned with the amount of length on your metatarsal, you can try to put that in there. And if you're not sitting proximal to that flare, you can see how it's going to kind of translate it laterally in the transverse plane, which is not something you really want. You kind of want more translation, not angulation. And so that first metatarsal head can really take on a totally different orientation. You can also see how the proximal aspect of the plate is really close to the TMT joint. I would, if I can't get that seated enough because it's just too long, I would probably take it back out, cut the last scallop off of the plate. They have those little scallops there. Just take a large pin cutter device and just cut the last scallop off before placing the rest of the screws. As far as plate placement goes, this is another key that I always teach people. I try really hard not to just put it in perfectly parallel. I think that leaves a little, especially if you don't have good apposition of your osteotomy, leaves a possibility of some teeter-tottering, which is basically just dorsiflexion of the capital fragment with just translation of the plate within the bone. The other thing you really want to do is you don't want to be parallel in the shaft of the metatarsal, in my experience. The plate is kind of designed to be touching the medial cortex medially and the lateral cortex laterally. And that creates a really nice flush surface for the distal aspect of the plate to lay on the medial cortex. And that really helps quite a bit as far as preventing that angulation of the first metatarsal head. So the angle of insertion, this is that angle I was talking about. When I put this in, you can see sort of on that second picture from right, I'm actually trying to touch the medial cortex with the plate and then touch the lateral cortex with the tip of the plate. And then I actually just try to skive this down until it actually touches like it does on the far right there. I want it to touch the medial cortex and the lateral cortex. I feel like that gives it the best stability and really allows for the best overall result. I will as well, a occasionally make the mistake of over tightening the oblique screw. This is what happens when you do that. You really translate quite a bit. A lot of people think that they're going to get more compression by just tightening that oblique screw. And really all you're doing is you're just translating the entire plate in sort of a proximal lateral direction, which if you already have a distal screw in there, you're really just changing the angulation of the first metatarsal head by following the arc of that oblique screw. So that's not really something I teach as far as something to compress. That's where I think the little Viking edition has really made a big difference, because you don't really need all of that compression anymore with that Viking device. That will really help to sort of align the osteotomy, keep it compressed, and then you don't have to worry about tightening anything down at the end. You can plantar flex. This was a case that I did showing sort of max plantar flexion. I don't know that I would recommend you do this on every case, but in this patient, it was really something I was really striving hard for. I think after doing this several times now, I think that's about the most I would ever shoot for. But she actually did quite well. And I think I would probably get a little bit more dorsiflexion. This patient actually developed a nice thick bone callus, and it wasn't prominent on the dorsal aspect. This is a case that had a broken medial cortex. That can happen, especially as you're tamping in that plate and you're trying to get it to rest both medial, distal, and lateral proximal. The medial cortex will fracture. It's not the end of the world, but it does make that medial plate prominent. As you can kind of see on those last two x-rays on the right, even though the osteotomy lined up well, the tibial and fibular sesamoids are lined up well, the plate definitely is sitting off there medially. So just a little too much angulation on that one. Something to be aware of. Here's some of my tougher cases. I typically will try to steer people away from doing the mini bunion if I get that tibial sesamoid over there in position 5. I just find that is a difficult bunion to correct. If they're flexible enough, and if I take that hallux and I can reduce it clinically and feel those sesamoids kind of slide back into position in the clinical setting, then I go ahead and I'll give it a shot. So I really do find that seems to be one of the most important things to look at. And then the next one is just a larger IM. This is a tough patient that had a previous subtalar fusion with another revision and was really putting off bunion surgery for a long time. She was also a nurse at the hospital I worked at the time. So it was really sort of one of those cases that you really don't want to go wrong. And she was dead set on a mini bunion, and she actually did quite well. I just went a little bit more proximal on her. You can see how I tried to sit a little bit more proximal, just proximal to the flare of the medial eminence, and got great results there at the end. The next one is probably one that, like a wish I had a chance to do again. He was not very flexible, but he was a slightly older gentleman that was a farmer, and yeah, he seemed real compliant before surgery, and everything was different afterwards. So you can really see that he was basically walking on it from day one. He was out in the field, he was feeding his pigs, doing all sorts of crazy stuff. I mean, literally within 2 weeks, he'd broken his oblique proximal screw, had significant shortening of the osteotomy, staking of the head there on the lateral cortex with some proximal translation. I think he broke his proximal phalanx with it as well. And you can see we coupled this with a nice Taylor's bunion. It was a dorsiflexory metatarsal osteotomy. On the next slide, you can really see how much dorsal displacement he got. And unfortunately, he got dorsal displacement both the first and the fifth, because we were trying to get it on the fifth. And he ended up with lesser metatarsalgia of 2, 3, and 4. This is the only one I've ever had to revise, and he was severely non-compliant. So I really think that had a big part in it. So with that, I guess I'll turn it over to Dr. Moore.
And real quick, I have a couple questions that came in.
Yeah.
Can you hear me, Dr. Young?
Yeah.
So first, this is for Dr. Lamm, and Dr. Young, you can answer this as well, since I know you use both systems. we had one of the attendees chat in that said, do you have a formula on when you use miniBunion versus DynaBunion Lapidus system?
Yeah, any hypermobility of the first ray, and I immediately start thinking DynaBunion, just because I don't want to have to deal with a recurrent bunion in less than 5 years. I feel like that's just not a result anybody's going for. And if it's really hypermobile at the first TMT joint, I don't. That's one indicator. Significant frontal plane rotation. So if those sesamoids are not reducible clinically, and the tibial sesamoids at position 5 or 6, I'm going with a Lapidus so I can rotate that entire metatarsal out of the frontal plane deformity.
Yeah, I would say that definitely the younger patients with the kind of more severe IM angles definitely would do a DynaBunion, because I'm worried, like Evan said, that you could get recurrence pretty quick. So I want to make sure it's a lifelong fix. Some other concerns are, like Evan said, if it's not reducible, if the MP joint is not reducible, you're going to have a tougher time with a closed or kind of minimally invasive approach to the bunion to get that MPJ back in position, as Evan alluded to in one of his cases, and also talked about that. So if it's non-reducible, then I'm concerned, or I may have to do more than just the typical technique for mini-bunion. And definitely these severe bunions, we're not trying to convince anybody to change their Lapidus approach. But what's fantastic about this distal osteotomy, which we'd rather, at least in my opinion, you'd rather do a distal than a proximal osteotomy just in general. That makes sense. And if you can do a good distal osteotomy, a lot of patients may qualify for that, even though they have a pretty severe IM angle. So I think one patient population, kind of the 60, 70-year-old patients who had bunions forever and they just want to get it fixed, but they don't want to go through, maybe a more elaborate procedure or recovery like a Lapidus procedure, that this, I've used and employed this very nicely in that patient population, because they can walk right after and usually heal pretty well, but they do have softer bone, and you have some of these screw issues backing out, the oblique screw, or you have the shaft being a bit of an issue with the implant.
Great. And we had a few other questions come in, but we'll save this to the end for Q&A so everyone can give their opinions on these questions. But keep chatting in questions, and we will get them at the end.
Okay, great. So moving along, next we have Dr. Moore, who practices in Virginia at Atlantic Orthopedic Specialist. He completed his medical education at Albany Medical College and his orthopedic surgery residency at Geisinger Medical Center, followed by an orthopedic foot and ankle surgery fellowship at the Penn State Milton Hershey Medical Center. Dr. Blake specializes in the diagnosis, treatment, and surgery of the foot and ankle, as well as foot and ankle reconstruction and general orthopedics. He has a special medical interest in treating athletes, lower extremity trauma, and complex hindfoot and ankle reconstruction, including total ankle replacement surgery. So I'll go ahead and hand it over to you, Dr. Moore.
Thanks for having me. Great
Sure.
talk so far. So excited to show a couple cases that I've done, and some of the tricks I guess I've come up with a little bit to help in my patients. So this is one of the first patients that I used miniBunion on, and like any trying a new procedure, I was a little skeptical. So it's a pretty easy bunion for my first experience with miniBunion. This is a 35-year-old female who, very similar to Dr. Lamm's presentation earlier, had multiple family members that had poor bunion experience with other procedures in the past, and so was more interested in proceeding with a minimally invasive option. Let's get these slides to advance. I had control, and now I don't. There we go. So this is the next slide with status post correction. This is with the 3.5 offset short plate, and augmented with an Aiken that was also done minimally invasive. and had fantastic results with this, and really was pleased with the rotational control I had over the distal fragment with the Viking instrumentation and being able to rotate the sesamoids beneath the metatarsal head. So this patient was back to regular shoes 2 to 3 weeks after surgery with a toe spacer, and had a pretty welcome and fast rehabilitation, and sent multiple other patients to our office for minimally invasive surgery afterwards. So word spread pretty quick with her results. So sort of pleased with that. And I'd done some other patients. You can go to the next slide there, and you can see that, you know, small incisions that she had. So she was very pleased with that and was able to get back into normal shoes pretty quickly. I will say that, you know, minimally invasive surgery, the swelling, you know, can take a little bit of time to go away. And so I usually recommend compression socks for most of these patients until they're almost 3 months out from surgery, just to help with some of that postoperative swelling. And that seems to help quite a bit. And then my protocol is very similar to the other panelists, but I use a toe spacer. I do one dress and change 6 days post-op, and then see them back at 14 days for suture removal, and then allow them to just use the toe spacer for a total of about 6 weeks, and then discontinue that. So this is a more complex case. This is a 40-year-old female ultra runner. So she runs 50 miles pretty much every week, and then we'll do 50-mile races. And in this patient, you can see that she's, in addition to the severe bunion, also has metatarsus adductus and has quite a bit of metatarsus primus varus. So she's symptomatic bilaterally. She's had pain on both sides and had put off bunion surgery for a long time. She'd seen, I think, 3 or 4 different opinions first, and was told really that her bunion was maybe even too severe to consider surgery, and that she would be at high risk for having complications. So I had a couple conversations with her for most of my running patients. The keys to keep them happy are just to don't let them stop running, let them keep running. And then secondarily, make sure you preserve the motion at the MTP joint so that they can dorsiflex there. If they lose motion at the MTP joint, they'll notice that almost right away, and they'll be very unhappy. So if you go to the next slide, I got a 3D CT scan on this patient to really evaluate the rotation distally and look at the position of the sesamoids. And really a lot of the pain that she was getting was from that sesamoid, that tibial sesamoid being right beneath the metatarsal head. And so, clearly when you're running 50 miles and you have repetitive stress, you're going to get continued pain underneath that sesamoid. So this is, one area where I think getting a weight-bearing CT scan, if you don't have access to that, getting a good sesamoid view in the office will help you sort of figure out where their symptoms are coming from and address that. Next slide. So for this patient, I talked about 2 different options. I talked about a maximally invasive option, doing a midfoot based correction with a lapidus correction of the bunion, and then doing an additional closing wedge osteotomy laterally of the second and third metatarsals to pull those out of the way. You really can't do a lapidus with somebody that's got pretty significant metatarsus adductus without correcting the second and third metatarsals, or you just won't have enough room to swing the first metatarsal over. Or I talked about a sort of a different concept, and one that I employed in another significant runner, not an ultra marathon runner, but a sort of a recreational runner, doing a distal based correction to really derotate the sesamoids out of the way, correct the bunion cosmetically with a zig for a zag, and really try to preserve motion at the MTP joint. Next slide. So after talking with her for both options, she elected to proceed with the minimally invasive procedure. This is an instance where I elected to use the long plate with the 4.5 millimeter offset, and also formed an Aiken, a modified McBride, and corrected some lesser toe deformity that she had of 2 and 3, and did an additional MIS osteotomy of the metatarsal to narrow the foot. She was having some bunion pain as well. And so this is the radiographic correction that she got. I was really happy with the sesamoid position and the overall correction of the metatarsal phalange joint. I did do a capsular plication on the medial side through the MIS technique via CrossRoads. And you can show the next slide will be her sort of befores and afters. So you can see the pretty significant correction in the overall alignment without a lot of shortening of the first ray. Which sometimes, is a little worrisome, especially in a runner. If you shorten the her hallux getting a stress fracture of the second can sometimes be a concern. So if we show the next slide, this is the immediate post-op appearance of the foot and the significant improvements of improvement of the alignment of the MTP joint. You can see the additional incision for the Aiken osteotomy and the lateral capsular release and modified McBride. But yes, this is a great experience for her. I let her go back to normal shoes with a toe spacer at 14 days, and she was probably running before she told me that she was, but let her return to doing some light exercise and running at about 6 weeks. And usually I like to see the early sort of primordial callus before I'm comfortable letting them do, any type of impact activities, but yeah, she's been doing great. So my pearls, I'll often try to angle the saw blade a bit distal so that when I'm translating the, when I'm doing my translation, that I don't shorten the first ray. So if you angle the saw blade distal, the capital fragment will migrate distally with the angulation of the saw blade and prevent over shortening of the first ray. So that's one thing that I'll do. My order of operations a little bit different with the Viking instrumentation. So I'll do my cut first, and then I'll insert the plate before I apply the Viking guide, and then I'll pin the capital fragment, derotate it out of the way, confirm that I like the rotation, fix it proximally, and then put in my screw fixation at the end. So I found that order of operation works well for me. And then again, I'm not shy with doing additional procedures, especially doing an Aiken osteotomy. I think that that can be really helpful in terms of changing the force of action of the EHL tendon, making it your friend instead of your foe, and pulling the phalanx more medially rather than laterally, and preventing recurrent deformity. I'll do a modified McBride if I feel like the sesamoids are hard to move, and I'll do a lateral release at the same time.
Thank you, Dr. Moore. Appreciate it. And we will conclude here with Dr. Curry. Dr. Nicholas Curry practices in Jackson, Tennessee at the Podiatry Clinic of Jackson. He completed his medical training at Rosalind Franklin University of Medicine and Science in Chicago. And Dr. Curry gained extensive practical training through a surgical residency at New York Presbyterian Columbia and New York Community Hospital. In his final year of training, he took on the role of chief resident. During his time in New York, he volunteered as a podiatry team captain for the New York Marathon. Without further ado, I'll go ahead and hand it over to you, Dr. Curry.
Thank you for having me. So at the beginning, I think everyone did a great job as far as technique and pearls and what we need to be looking for when doing this and what to do, what not to do when picking for the mini bunion. I've done similar to Dr. Young, probably about 60 or 70 of these now. All of them actually gone very well. I've had very few complications, and we'll just go over a couple of those and how they were fixed, and then go over the new Viking system. I've been able to play with it for a couple of weeks now, and kind of how it's made those little things during the case that much easier. I had a 44-year-old female with no comorbidities. She worked retail. She was an excellent candidate for the mini bunion procedure. She went under the surgery without any complications. At 11 months post-op, she started having some trouble with the exostosis. Dr. Lamm went over this a little bit earlier, and he's kind of started shaving that medial osteotomy site where people are having pain. She had a steroid injection, did better, but was still having pain overall. A small exostectomy fixed that very quickly. On all my cases now, I do them to start out with, but this was one of my first. And that was one thing we kind of learned, that osteotomy exostosis can happen over time. My second case was a 58-year-old female. This is status post 3 days. Her AP is in a very supinated position, but she was doing well overall with very little swelling and pain. She had transferred to a sneaker at 4 weeks and she was looking great. Came into me about week 6 saying she's been having pain for 2 days. We took images and we could see dorsiflexion of that capital fragment with a little bit of abnormality up on that dorsal cortex. What we went in and revised it, and what actually happened is she had a small fracture on the osteotomy site on the medial aspect. If we look at the pre-op x-rays and post-surgical, the oblique screw was in a great position. It was not close to the osteotomy site. But what I did learn is that when we take out those 2 K-wires that we place the cut guide with, we do bend them. I have decided that when I bend them back, I actually just remove them by hand by twisting them back and forth. At the beginning, I did bend them straight, take a K-wire driver, and then undrill them. And I think that caused a small stress riser, which then led to the fracture. She did great with ORIF with just a straight plate. One of the greatest parts of it is she kept all of her motion in that first MPJ, even through 2 surgeries. The surgical pearls, like I said, just burr that medial side and prevent stress while removing the K-wires. As others have already said, some of the great things about the mini-bunion is that we're not going into that joint space. We're able to keep excellent range of motion directly post-op and even 1-2 years down the road, where before with some of my distal bunionectomies, we would get some capsular adhesions and limited range of motion of that MPJ, even though they did physical therapy and were very active afterwards. With the new Viking kit, this is it pictured right here. You place 2 K-wires through the capital fragment, and you're able to control your range of motion in both the sagittal, transverse, and coronal plane. Just a couple small pictures that I made. With that there, we are able to control that rotation in the capital plane, coronal plane. One thing that I did see when doing the mini-bunion is sometimes getting enough rotation and correction there. I would have that kind of a round appearance to the capital fragment as seen on the right. But with that Viking system, you always get that sharp image that you can see on the distal aspect of the metatarsal head laterally, and you'll always see that on intraoperative fluoroscope, knowing that that has the correct correction. The other thing that I would sometimes run into is when you make that osteotomy and the capital fragment kind of slides or transverses to the lateral aspect, we would get tilting, and you kind of have this capital fragment tilt over, and then you'd have to find its way back to have good bone-to-bone apposition at the osteotomy site. Having those 2 K-wires with that Viking system allows you to rotate both of the wires in different directions to easily get it back to good bone-to-bone apposition. And then, as Evan was saying earlier, when you pull that in a proximal direction, you get that compression that you don't have to rely on that oblique screw for. You pin it in place, you retake your images, and then you just go ahead and you finish with your screw across that capital fragment. So overall, it was a great procedure that everyone went over, and this Viking system just makes it that much better and easier to deal with some of the small things that I've worked on over time, making sure that I don't have to spend time fixing throughout the procedure.
Great, thank you everyone for your presentations. At this time, we will go ahead and do some discussion. Scott, are you on?
Yeah, we have a few questions. Dr. Lamm, if you just wanted to talk through your pearls with practice marketing with MIS, this is kind of one of the topics that came up in some questions and also that we had planned. So each you want to just talk about the power of practice marketing with MIS and Dr. Young, for example, I know we've had many patients who've driven long distances to come get this procedure. So just want to talk about some surgical pearls on best practices for that. That'd be great.
Yeah, I think just from my standpoint, it's definitely, as Blake indicated, patients that are happy, they're very willing to spread the word locally. And before you know it, you're going to have a lot of new patients in your office because of this procedure. And it definitely is revolutionary because it is so less painful and less scarring, and definitely patients love it. They're not worried too much about the x-rays. Mostly they feel it doesn't hurt so much, that looks good, and they're really pleased. So I think that you know, the patients are going to demand this, and it's important that you know how to do this procedure. And hopefully all these pearls that we gave you tonight will definitely help you. But it's definitely a practice builder. I'll turn it over to Evan next, and then Blake, and then Nicholas. If you guys could give also your thoughts on how the mini bunion has changed your practice.
Yeah, I think everybody is looking for a minimally invasive bunion technique now that they've kind of seen that is on or out there as a possibility. I have patients that come in and they literally will come in and say, I need this bunion fixed. How do you do it? And then what they're looking for is for you to say a minimally invasive technique. So, I mean, I think having this system or having gone through this system and trained on some other ones as well, I've been really, really pleased at how short the learning curve is for this one. Even my first 3 and 4 patients that I did all did wonderfully. You know, it just took a little longer than it currently takes, but you're still talking about a bunion case that takes 45 minutes at the most. You know, and really with the new Viking edition, I think, you know, I've gotten it down to 20 to 30 minutes, and I don't have to, you know, finagle the capital fragment for 10 extra minutes or anything like that. It just holds it in place, frees up your hands. I think that you can really tell the patients with a strong degree of confidence that you're feeling like you're going to do a great job for them. And, you know, and that really helps not only sell the patient in front of you, but it also helps with every outcome. And then they just start sending you friends, family, and they can't believe that it went so well, you know, because their aunt and uncle, whoever had it done 20 years before, had such a horrible experience with it. So it is nice to give that to them.
Blake, you want to give your
Yeah, I mean, I'll echo a lot of the things that Evan just said. I think that there's, you know, quite a few, you know, probably 3 or 4 reasonable, minimally invasive options to correct bunions at this point. But in my opinion, you know, I found in my hands that the CrossRoads mini bunion system, at least in terms of doing a distal metatarsal osteotomy, is the most reliable in terms of the fixation. And it's dependable. I think having, you know, the plate sit interosseous and then having the capital fragment rotational control sit on the medial cortex gives you both axial stability and rotational stability. And so that, you know, I have a lot more confidence that wherever I put that correction, it's going to stay there until it's healed. And so that's one of the reasons why I prefer this system. But I'll agree, you know, a lot of patients come in, you know, what they want to hear is that they're going to have a minimally invasive surgery, and that they'll really leave it up to you in terms of how you're going to perform it. But, you know, that's why I choose this system.
Great. We have a couple more questions that came through now. If you all want to go through and address your thoughts on these. We had one question and that asked, are you reflecting the periosteum at all or cutting right through it?
Yeah, I would say that we're basically leaving the periosteum alone and just doing the osteotomy through the periosteum and leaving that lateral periosteum mostly intact, not to plunge through there, as I think Evan mentioned, so that when you translate, you're really stretching that lateral periosteum, and that's what gives you that great healing potential. But it does take, you know, 3 months, sometimes 4 months for some of these patients to form that solid bone over there. Nicholas, any other comments on that one?
No, same thing, just small incision, get rid of the deep soft tissues, put the cut guide on and cut straight across.
And then we had a couple more questions, and Dr. Moore, I saw you answered this in the chat. So if you want to speak to this on your thoughts on why using a bunion blade as opposed to a high-speed Shannon burr that's popular in some other indications recently to create that osteotomy.
Yeah, I mean, I've tried it both ways. I've tried with the burr and I've tried it with the bunion blade in the prescribed technique. I think that the burr just creates a lot of heat and a lot of bone debris at that area. That's why, all of these burr systems have a irrigation system to try to keep the heat down. And I think that that's fine if you're not making any incision at all to have that heat generation and have the swelling afterwards. But if you're going to make an incision and plate that area, it's really not suitable to use a burr in that instance because I just think you're going to have some wound complications. I had a couple very early on, and so I went back to doing the technique as described.
Great. Well, that is all the Q&A we had. Dr. Lamm, if you want to close us out and with a mention of your patient videos here.
Yeah, so just wanted to share with you patient
I wish I would have had this done 10 years ago. It was very, very easy. The surgery in the recovery was much, much easier than I had anticipated. And if I had known it was going to be as easy as it was, I would have done it years ago. I'm currently 16 weeks post-surgery and I'm pain-free. I'm now playing tennis 6 days a week. I'm lobbing, I'm getting to the net, jumping on my foot, and I'm pain-free and I feel fantastic. I can wear any shoe now that I want to wear, and I'm going to go buy more.
Yeah, so it's really rewarding, as all the panelists mentioned, to be able to provide this minimally invasive procedure and have people get active quickly, have less pain, and makes
I wish I would have.
makes us as a surgeon look really well. And I think some of the tips and tricks you've heard from all the panelists are just working through the nuances of getting used to this procedure. And I think that once you get used to it and you get familiar with it, you'll find it very powerful, as all 4 of us have found.
Great. Thank you, everyone, for your participation. Thank you, attendees, for joining us and your great questions. And thanks to all of the panelists. We really appreciate your insight and your contribution. We will have the recorded version of tonight's webinar on the FootInnovate website within the next week or 2, and everyone will receive an email with a link for them to access. So thank you again to CrossRoads. Thanks, Scott. And thank you to all of the doctors.